Welcome to the PA Insights podcast, powered by NCCPA. This episode is brought to you by the Partners in Mental Health Initiative, sponsored by the NCCPA Health Foundation. This is part 2 of our conversation with Jay Summers and Todd Allen, 2 seasoned PAs who work in psychiatry and remind us that mental and physical health are never separate. In this episode, Jay and Todd discuss the art of whole person care, how their generalist PA training equips them to treat both the body and the mind. They also talk about collaboration across teams, the importance of self-care, and why empathy and purpose are essential to long-term fulfillment in medicine. It's a thoughtful look at the future of mental health practice and the vital role PAs play in improving lives every day. Enjoy.
Share with us an experience about, the medicine or physical health comorbidities that you tend to see or that you tend to care for as a psych PA.
Yeah, I mean, it makes me think about what you had said before about, seeing these people. We have them on medicines that can be potentially dangerous, right? These antipsychotics, these antidepressants that we're, using frequently, in almost all our patients. And they can have some serious metabolic side effects, right on top of all the other stuff that we don't quite really know about them yet. So we're using drugs that are affecting an organ that we don't understand very well, in a system, in a body system where we're not understanding the role of inflammatory markers, of gut bacteria, hormone signaling, in a way that we'd like. And so being able to kind of think about how we do those things. I remember early on in my career, I had a patient with bipolar disorder on Zyprexa, olanzapine, and I started seeing their blood sugars kind of creep up a little bit, and I started, and it had been one of the few times that I had I think, I just started using those antipsychotics, like year before, right? I mean, we never used them in family practice, right? So that idea of saying, okay, what do I do now? Do I need to refer them to an endocrinologist? Do I need to refer them back to their primary care provider, right? But it was not only partially because of my medication that I had prescribed, but it was also my responsibility as a whole care provider to be able to think about okay, let's do some labs. Just like you, I take a blood pressure and a pulse and a weight on people every time I see them. And being able to track those things, because so many of the times, those people aren't seeing primary care, right?
That's true.
25, 27 years ago when I came out of medicine, it was obviously a lot more common for people to see their primary care doctor and then to get referred to psychiatry. Now it seems like at least half of my patients don't have a primary care provider, and so that idea of saying, oh yeah, look at this, it's, these people aren't getting the care they need. They're not having anybody talk about their weight. They're not having anybody talk about, diet or exercise or social connection or any of these other things. And I realized that I could start taking that and saying, yeah, there are times when I'll prescribe, metformin to somebody if they're doing that, or I'll say, this olanzapine or whatever I have them on is causing problems. Are there other things that we can do, right? How do we address this on a physical health basis, right? How do we look at that and take my part in that role and not think, well, it's not my job. I'm in psychiatry anymore. I don't have to care about your body,
Absolutely.
right? Which is just a ridiculous concept, right?
That's true.
So absolutely. But all right. Well, within that framework of talking about, how we handle physical health and mental health together, do you find, as a kind of a state health provider, that you're interacting with specific provider types or the people you collaborate with the most? What does that look like in your setting?
Yeah, so each one of the settings that I work in, the collaboration tends to be a little bit different. For example, in the state hospital, I work on a particular unit in the state hospital, and so each unit has a physician assistant and a psychiatrist, and so the psychiatrist is taking half of the patient load. I'm taking the other half of the patient load. But we have our treatment team meetings every morning where we talk about, all of the patients on the unit. And so even though I'm carrying my patients and the psychiatrist is carrying their patients and stuff like that, we're both incorporated into the care of the other individual's patients and stuff. And so in that setting, I do have a psychiatrist that is there, is involved in the care of my patients, is available to answer questions when I do have questions and stuff like that. So that person is always there for me, which is very nice to have that resource there. In my outpatient setting, it's a little bit different in that I do have a collaborative practice physician, but the physician works in a different office on the days that I do my outpatient clinic and stuff, and so I don't really collaborate a whole lot with that particular provider. But there again, it's one of those things that the provider is there and available. If I do have a question, hey, just ran into this situation, this is what's going on, I don't know that I've ever really seen this, I've tried this and I've tried that, but it's not really seeming to work. What suggestion do you have? Is there something else that I can be doing, right, to help my patient a little bit better and stuff? And so I do have that collaboration, but it's a little more removed than what it is when I'm working in the state hospital setting and stuff.
Yeah.
So that's a really good question, Jay. I mean, obviously you've worked in different areas of family medicine, psychiatry, and stuff like that. So what collaboration do you have in the setting that you practice in?
Yeah, I do all outpatient now in my clinical practice, and so for the most part, it's interesting. I would say the people who I interact with the most are probably therapists or family practice, either physicians or PAs, nurse practitioners, talking to them about either I'll getting referrals from them, but once I have them in my practice, then I'm always getting back to them and saying, especially therapists who I love to be able to share patients with, because they're getting the patient, 4 times a month or sometimes even more, or sometimes less depending on how they're doing, but they're seeing them a lot more often than I'm able to see them, right? And they're doing the deeper therapeutic work. And I always tell people, I joke with them and say, like if you have a whole mental health pie, I have like 25% of the pie, right? In the end, my ability to influence the outcome is relatively limited, right? So I think it sets the bar of saying we're not going to find this answer with a pill, right? Lifestyle changes, therapy, sleeping, nutrition, healthy relationships with your spouse and your friends and your work environment, that is the whole rest of it, right? And so talking to people about that, making sure that they're following up on it. I do a lot of care coordination, but in the end, I really love to be able to talk with the therapist and say, oh, I just saw John Smith and, he's doing this and we're changing this over here. I'm going to see him back in 3-4 weeks. And, what are you guys working on? Certainly talking with, I have several people now where I'm getting referrals from the primary care provider and they're saying, oh, okay, well, this person, they're dealing with AFib and they're dealing with high blood pressure and high cholesterol, but they're also having, depression issues and I really would love for you to see them for this. And then we kind of go back and forth like, oh yeah, they want to just, their cancer's getting worse and okay, so we're trying this. And so then I can take a look at, okay, what's the environmental stuff going on, right? What is happening within this environment that may be influencing their depression, influencing their anxiety? Maybe, if their blood sugar is 300, guess what? Maybe the antidepressant's not working, not because it's not working, but because, their liver's not metabolizing it, right?
Absolutely.
I mean, they're just, they're just struggling to keep up, right? So looking at those things, right? How do we think about, the absorption, right? If you're having GI distress, guess what? Your antidepressants aren't going to work very well either.
Correct.
Right? And having nothing to do with the antidepressant.
Yep. So
we have to look at that whole picture, and I think if we can do that through coordination with, primary care, their internist, with the therapist, if you have the ability, I'm sure probably in a state hospital, maybe even in your outpatient, you have that where you're seeing those therapists and you're working with them all the time and stuff, right?
Yep.
So I mean, that's great. When I worked for a group practice, that was always the thing that I enjoyed the most about it, not the administration, which is always a hassle, but it was the hallway consults, right? It was the fact that, like, oh yeah, I just saw your patient and, and then we will have a little 5 minutes right out in the hallway between patients, right?
Yep.
That was great. And I think to me, that's the kind of, it takes a whole village kind of thing. Right?
Sure, absolutely.
So yeah, I mean, that's kind of where I look at it.
All right.
So, we've been talking about a lot of different things, obviously, how we integrate medicine, how we think about our family practice backgrounds and our generalist backgrounds and stuff like that. Is there something that you wish that like all PAs throughout the country knew about psychiatry or mental behavioral health that you think maybe is missing?
Yeah, so the one thing that I think really is important for all PAs to know is that no matter where you are, no matter what area of medicine you're practicing in, you're going to see it, right? It's at varying degrees. But be prepared for that, because you really are going to see it. And I know that there's a lot of people out there, providers, that are kind of a little bit nervous about talking to people about some of these disorders and stuff like that. But I really want everybody to know that, you don't have to be knowledgeable in all areas of mental or behavioral health to be able to be efficient, to be able to help somebody that is struggling with those kinds of issues and stuff like that. A lot of it is just very simplistic. It's just starting the process and stuff. So I would really encourage all of the Ps out there to just have a firm foundation, right, in what it means, and understand and know what your limitations are. You and I both been doing this for a long time, right? So our comfort level with dealing with these kinds of illnesses and stuff, totally different than somebody that has worked in family practice their entire career, somebody that's worked in orthopedics or something like that. But just know, no matter what area of medicine you work in, you're going to see it. Try to get a strong foundation in it. Doesn't mean you have to be a master of it, right? You have to know everything that there is to know about it. But I would really, encourage all of the PAs out there to really just focus on getting a strong foundation, so that you at least have some degree of a comfort level when you are presented with these kinds of situations, because the reality is it's going to happen. Right?
Yeah, it's really insightful, and you're right. I mean, we encounter psychiatry and mental health in so many other areas, and so so much I think of the barriers that we face have to do with not feeling like, oh well, we're not qualified, that's not our area, so what can we do about it? So
yep, absolutely.
Very, very interesting.
Yep. Is there anything else that you would like to share about what you think all PAs really should know about psychiatry or mental and behavioral health?
Yeah, the interesting thing to me is, again, this concept that we're talking about them as different things, right? Which I understand just as part of the language and is part of the problems that we face. I think part of the reasons why we don't think about psychiatry as part of medicine is we don't learn about it necessarily as well in school, and we don't get the common threads, right? I mean, getting back to my philosophy background, right? It's, to me, why do we treat any disease? Why do we treat hypertension or cholesterol or cancer or depression or schizophrenia or, OCD, right? We treat them because it makes a difference to the patient, because it addresses quality of life, finding purpose and meaning in life, right? That's why we do the things that we do. And I think if we identify that as the common thread through all of medicine, then treating depression or bipolar disorder is no different than treating cancer or diabetes.
Correct.
Right? I mean, thinking about that, and I think that breaks it down for the family practice provider, for the internal medicine provider, for the psychiatric provider, right? In the end, we're all treating medicine, right? PAs practice medicine. Right, that's the kind of saying, and that involves not just physical health medicine, right? That just involves the things that we think of, like, oh, okay, we think about cardiology or dermatology or other things like that. It involves addressing the reason why we're treating any of these conditions is because it matters to our patients for their quality of life, right? Whether or not we live till 120 or whether or not we die at 50, what we hope, and obviously when we die at 50, it's tragic, but it's not like if you live to 150, you can be super happy either. Sure. I mean, I think we spend so much time in Western medicine focusing on quantity of life, right? We put people on ventilators for the last 10 years, we give them all these medicines, we do dialysis, we do all this stuff, right? The only point in doing any of that is if it improves their quality of life, right?
Absolutely.
I mean, so having somebody who can't eat, who's in a hospital for the last 5 years of their life, like, what are we doing, right? But I think it's about having the discussions. In the end, like I said, this is not my journey, right? right? This is the patient in front of me.
Sure.
And if I can help them identify those things, whether or not that's about end of life, or whether or not that's about what is important to them when they're 40 or 50 or 60, or when they're struggling in school when they're 18 or 20, how do we think about these things? How do we help those things? And realizing that, I tell people, frankly, I tell them, sometimes life sucks,
Yep.
right? Sometimes life is hard.
Yep.
It's not supposed to not be hard.
Correct.
Right? I think when we think about what all PAs are doing, we struggle because what we're doing is we're problem solvers, right? We in medicine are problem solvers, right? We okay, you have high blood pressure, you have diabetes, I got this great medicine for you, I got this thing, maybe you should get out and start training for a marathon, right? And we have the solutions, right? What we're not often asking is, why are we offering those solutions, right? What, maybe the marathon is not the right answer for that person, right? Maybe the person smoking a pack of cigarettes a day who's starting to have, early signs of emphysema or chronic bronchitis, maybe stopping cigarettes is not the right answer. I mean, I know that that's blasphemy, but the fact of the matter is, it doesn't matter what I think, right? It doesn't even matter what the studies show or what the research shows, right? And you can have as many double-blind, placebo-controlled studies as you want. In the end, what matters to the person in front of us, So I would love for us to be more comfortable with that, and I think that probably just comes from experience in whatever field. I mean, I think if you were an orthopedic PA or a dermatological PA or family practice for 10 years, being comfortable with the person in front of you and just saying, you know what, I'm not sure what the right thing is or what other antidepressants maybe are out there, or if I should do augmenting agents or what. But I know that I want to focus on your quality of life and what is important to you.
Exactly.
Right? And I think that relieves some of the tension on the provider, because it's not like, oh my God, we have to have all the answers, or we have to know the latest science on what new mood stabilizing agents are out, or what the research is on sleep or nutrition or the Mediterranean diet or whatever, right? I think that we start from a foundation of saying, this is good for the patient and it makes sense for them, right? It's the right answer for their situation where they are.
Correct.
Because they've decided it was.
Yep, absolutely.
So, yeah.
All right. Let me present you with a scenario here, Jay. So you have a PA that's working in another area of medicine, and they express that they have an interest in psychiatry. What advice do you have for them?
Well, first I would ask what interests them in psychiatry, right? I mean, I can think about all the things that interest me in psychiatry, and so, of course, from a narcissistic perspective, I think, oh, well, those are clearly the most important things, right? But in the end, just like when we're talking to our patients, when we're talking to fellow providers, when we're talking to people, maybe even before PA school, right, and they're interested in different fields, what is it that they think, right? I mean, I think we all realize, probably coming into that, we talked about our early experience prior to becoming a PA. We think about what we thought of psychiatry was, or psychology, right? And we're like, I'm not going into that, right?
Exactly.
But the reality is, just like saying, if you ask the average 15-year-old or even 20-year-old, like, what do you think it is to be a doctor? What do you think it is to be a nurse? What do you think it is to be, an air traffic controller, right? We have these concepts based probably on TV and the internet and movies, but we have no practical consideration of what that actually means, right? So talking to people about what motivates them or what they think psychiatry is, and I think, interestingly enough, and I've certainly found this throughout my career, and I've been so incredibly fortunate to have had so many diverse experiences, it's important to note that it's not one thing either, right? I mean, I meet people from all over the country. I mean, you're a great example, like somebody who's worked in the state mental health system, but also does outpatient work, who is in an institutional setting and obviously works in that. I've met educators, I've met researchers, right? Leaders who are doing amazing things, doing administrative work and leadership and developing new structures and business entrepreneurs and doing, products. And I mean, so much is there, and I think that when you talk about psychiatry, it's like, what do you see, right? I mean, somebody who can think outside of the box and say, yeah, I love clinical medicine, I'd love to work at a state hospital, or I'd love to work in an outpatient setting, or I want to teach, right? Or I want to work for a doctor of medical science program and do the more advanced clinical work and help PAs who've been out in practice for 5 or 10 or 15 years, do more or maybe transition into a new field. I think that would be great. I'm always trying to talk to people about, certainly what I find interesting in psychiatry, which is the passion about quality of life. But I want to figure out what they care about and what it is that they see, and to a certain extent counter some of the belief systems. Usually it's more the belief systems like, oh, well, psychiatry is going to be boring, or it's going to be overwhelming, and I'm just going to have 15 schizophrenic patients all day long, and I'm not going to be able to connect with them, and certainly there are practice settings like that. But trying to figure out, like, medicine is just so incredibly diverse.
That's correct. Yeah.
So making sure, and especially for our new grads out there in the first 5 years, right? I mean, you hear some unfortunately, tragic stories about, people getting caught up in the wrong settings and in places that don't support them necessarily. And I think that a lot of that is due to the fact that we don't recognize that there's so many other things that they could be doing, right? Like, if this isn't working out, if somebody doesn't see your value, Maya Angelou has a great quote that I'll probably butcher, which says, when somebody shows you who they are, believe them the first time.
Yeah.
Right?
Yep.
And,
Exactly.
I think you gotta pay attention to that, right?
Yep.
And I think you have to have enough belief in yourself in order to do that too. So I think it does take a lot of emotional maturity, certainly, that, not just what we think about with maturity and being older, but that, kind of ability to know ourselves too. So, but yeah, I mean, what's your perspective on that? I mean, do you have something that you think that would be helpful?
Yeah, so, and I agree with you, right? I mean, the person has to recognize what they have a passion about, right? And they need to recognize that. Excuse me, but they also need to stop and think about or recognize the fact that when you're talking about psychiatry isn't just outpatient. Psychiatry isn't just inpatient. Psychiatry isn't just addiction medicine. Psychiatry just isn't the VA, right? I mean, there's just not just corrections, right? So there's so many different fields or different, avenues that you can go into psychiatry related in the field of medicine. So it's not just psychiatry, right? Because there's so many different things. So I think the person really needs to stop and think about what they have an interest in as far as that goes as well. One of the things that I have talked to people about in the past is they're like, how do I break this like ceiling? How do I get into psychiatry? Because I don't even know where to start, right? And so, I think that, a good way for them to make that approach to it and stuff is talk to their coworkers, right? Talk to their networking people and stuff, because they all remember the majority of their classmates when they were going through the program. They all have some connection with somebody that maybe has a way to get into it or whatever and stuff. But just encourage them to network, right? Go to their preceptors and stuff. Say, hey, I don't know if you remember me, but I was a student of yours 2 years ago. I'm really trying to get into psychiatry. And do you know of any positions that are open? Are you looking for anybody and stuff? But it really is about going out and starting to ask the questions and starting to look to see what's out there and available, because a lot of these jobs or these positions are not posted out there. They're word of mouth jobs, and so the more that you communicate with your coworkers and the people in the field and stuff, the more likely you are to be able to find something in that particular area. But I do think it's important to have an understanding about what area of psychiatry you're interested in, so that you can kind of divert your effort into looking for something in that particular perspective or that particular modality.
Yeah, that's a really good point. And I would probably, add on that, like, I think state conferences, even national conference, those are just an extension of the networking.
Yep.
Right? I mean, in the end, it's, these days, especially at AAPA, there's so much that, that people do in individual states and stuff like that. Even if you want to stay in your individual city and look for a job there, state conferences are great, regional conferences are great, but, talking to AAPA and getting on the job boards, obviously, in the past 10 years, obviously LinkedIn has taken off and all of this stuff, but you can get overwhelmed and think, oh my God, there's nothing I could do, or I just don't know where to start. So I think starting from your local network is a really valuable thing, because it brings it down to, like, people you've interacted with before, and like, oh yeah, what are you doing, or have you heard about something? I mean, that's how I got the first couple of my jobs. I mean, it's just all word of mouth, and obviously these were earlier days, but thinking about how we sort those things out, and then I think you're right about being real clear about what your intention is, what it is that you want, and maybe asking people about, oh, what do you like about this? Oh, you do teaching. Oh, you do inpatient work, or you do outpatient work. Oh, you're at the state hospital.
Yep.
What is that like?
Exactly. Yep.
So,
All right. So once again, imagine that you have a PA student that comes up to you and says, hey, I have an interest in getting into psychiatry. What thoughts would you share with that PA student that has an interest in psychiatry?
Yeah, I mean, I think that is a wonderful thing when that happens. I think it's still in the minority, sadly, because I think there's still, despite all that we've learned and understood and all the kind of physiology that's come up out of psychiatry, especially, since you and I both graduated. I mean, the things that we're seeing, all the connections that we're seeing, more and more, and every couple of years we get a new, like, oh, it's this, oh, it's C-reactive protein, it's homocysteine, it's IL-6, right? All these little things that we're recognizing. I think that we're still struggling to find people that identify and say, because I think, we still have this stigma that psychiatry is still about what we see in the state hospitals or in the VA system, and those are really at-need patients, but the fact of the matter is most of the settings throughout the country are not that, right? That's a huge, huge need, but trying to figure out how to treat people and to focus on quality of life and on purposefulness and meaning and sadness and things like that. I mean, these are things that all of us will experience, right? We talk about people experiencing sadness but not depression, yep. Right? And one is a diagnosis and one is a symptom, right? A symptom of life, really. So talking to PA students about what it is that they care about, what they see, similar to talking with other PAs, right? Which is that, what do you think psychiatry is, yeah. Right? What do you think you'd be doing, or what do you want to do in psychiatry, mm-hmm. Right? And I think we're at an inflection point in psychiatry, which is kind of funny because psychiatry's been around for a long time. I mean, the American Psychiatric Association is the oldest psychiatric association in the United States. So organized medicine in psychiatry has been around forever, mm-hmm. And yet we're I think starting to recognize the incredible power that we can think of when we talk about psychiatry, when we talk about mental health and behavioral health and quality of life. And we can start getting the people who are like, oh, I really want to recognize they're being talked about burnout and professional fulfillment, and they recognize that there's a lot of stress in medicine, and like you talked about coming home with these things, these people aren't doing well, and I'm like weighed down with that, right? And that is something, of course, we need to deal with. But in the end, when you spend your day focusing on people's quality of life, you focus on your own quality of life. Correct. Right? It is therapy and healing for yourself.
Brings it in perspective absolutely. For you.
Yeah, absolutely. Yep. And so, doing that, I think, is really, really helpful. And I would ask PA students about that, and I would ask them to reflect on that. I know it's been several years since I take students, but I know you have tons of students that you rotate with all the time, so I'm sure you must be giving this advice out all the time. Tell me some of the things that you talk to students about.
Yeah, so, and you and I both know psychiatry is not for everybody, right? I mean, it's people have different, interests and stuff like that, and we both agree that psychiatry is not for everybody, right? The one thing I can tell my students is that I love what I do every single day. I love the fact that I work with my patients, and over the course of the time that I work with them, I see the change. I see the improvement. I get a sense of satisfaction and a sense of accomplishment every single day, right? And that is what I love about my job. And I tell my students, it's like that you can find that as well. And I know that every area of medicine has a certain degree of that, but I would argue that a lot of areas of medicine don't have that every single day, right? A lot of times you, depending on where you're at, you see a patient on day one and you might prescribe a medication for him, and then you might not see him again for another year and a half or 2 years, depending on when something else comes up or whatever. So it's hard to get that real sense of satisfaction, that sense of accomplishment when you're working in that kind of an environment. However, when I work with my patients in psychiatry and mental health and stuff, I get that every single day. And I don't ever have to worry about waking up and saying, man, am I going to do something worthwhile today? Because I just know that's what's going to happen. And so that's the one thing that I would encourage the students to think about, is there really is a fair amount of job satisfaction, right? This sense of accomplishment when they are practicing within the field of mental or behavioral health.